Good morning and welcome back to another episode of Child Please Podcast. I am one of the founders and visionary, Erica Simpson,
And I am Regina Weathersby.
and I am so excited this morning to have one of our own. Um, she's such a special person to me dearly, as well as to our organization, Miss Caitlin Weimer, who is an RN. She's been a nurse for about 15 years, and she is our own, the Blue Rose Foundation maternal wellness education coordinator. That was a mouthful. So we just gonna jump right into it. February honors a lot of things from Black History Month to Valentine's Day to Heart Health Month. And so today we're gonna use for a topic today, heart matters. And we're gonna talk about heart health as it relates to Black maternal health, Black moms, pre-birth and postpartum. So I'm gonna turn it over to Miss Caitlin Weimer.
Good morning, all. As Erica said, I'm Caitlin. I've been a nurse for about 15 years. My background is trauma burn ICU, case management, and pre-admissions case management. And yes, I know it's glaring. I do not have directly any maternal health. I've not been an L&D nurse. I'm not a baby nurse. But as a case manager, I have seen the heart side of maternal health. Especially when the serious side of what can happen. And the two big things I wanted to talk about today are peripartum cardiomyopathy and gestational hypertension. Both of these have very different manifestations, and their symptoms, especially in Black women, can often be set aside, downplayed, or seen as something else completely. So the first one I wanted to talk about, we'll just go ahead and start with peripartum cardiomyopathy. It is a rare disorder. It does not affect very many women. However, what it is, it's where pregnancy takes a toll on the body. You have higher blood volume. The heart is having to work much harder because now it's having to supply blood to mom and baby. It usually shows up in the last month of pregnancy, but can still manifest 5 to 6 months after the baby is born. And what specifically peripartum cardiomyopathy is, it's a dilation of the left side of the heart. And the left side of the heart is the side of the heart that pumps the blood to the body. And it's actually a weakening of the heart muscle itself. So it causes the heart muscle to become big and floppy to where it cannot pump blood out to the body like it's supposed to. And Black women specifically, I did some research, really wanted to bring this home, but they are 3.5 times more likely to develop cardiomyopathy and have more adverse outcomes, such as requiring an implantable defibrillator due to arrhythmias, poor cardiac recovery, resulting in lifelong medications requiring close follow-up with cardiology, and if severe enough, a heart transplant. And the sad thing is with this cardiomyopathy, it may be asymptomatic. You may not know until it's too late or the damage is too far to where minimal, mild interventions could help with recovery and that you could live a normal life. Some of the symptoms that women may experience but may easily write off is they go to bed at night and they keep waking up short of breath. They usually lie flat. That's how they normally like to sleep. But now they got to sleep propped up on pillows. You may not think anything of it because, nobody ever says that's a symptom of something, but it is. It is a symptom of heart failure. Another one is just, they may get just breathless. They're walking, they're trying to pick up their kid. Maybe they're on their second baby and the heart failure didn't show up in the first pregnancy, but it's in the second one. But it wasn't picked up because most women, birthing age is young. Even when they call it, a geriatric pregnancy or advanced maternal age, those women are still young. And so most practitioners don't think about this woman being heart failure until it's too late, especially for the fact that it is so asymptomatic. Oh, oops. Sorry. My computer just flashed. Um, so another thing is gestational hypertension. This is common. A lot of women do get this. And medically, what it means is when you have a blood pressure of 140 over 90 for greater than 2 occurrences without protein in the urine and ketones, and that's the scientific term for it. Um, However, hypertension in pregnancy can have lifelong consequences, especially if it's not treated or if there's a lack of follow-up. Um, Personally, I have heard of women who, and I've heard this a lot. I've just heard it in stories. I have heard it in just in passing by. I've read it in many H&Ps on patients when I'm reviewing charts of they had gestational diabetes, but when they left the hospital, they left on those blood pressure medicines, but they didn't have follow up. They were not told they need to go see a cardiologist, or they were told, oh, you need to go see your PCP because the OBGYN is not going to want to manage the hypertension. So you can have a scenario of mom goes to all her prenatal care. She gets diagnosed with gestational hypertension. She started on blood pressure medicines, but the doctors didn't mention that there are side effects with these blood pressure medicines. Blood pressure medicines can make you feel very tired. They can make you just feel worn out. And the body gets used to the feeling of hypertension, especially not just in gestational hypertension, but in hypertension in women after they've had a baby down the road in life. And your body get used to that. And then all of a sudden you take that blood pressure medicine, it knocks your blood pressure straight to a normal. And now your body is like, what is this? And a lot of people don't like that, but they don't know that that's a side effect, or they get real dizzy. So if you've got a new mom at home and she's trying to take care of her baby and that blood pressure medicine is causing a real quick drop in her blood pressure, so she gets dizzy, she may be carrying that baby and she's worried, she gets dizzy. I might drop the baby. She doesn't want to do that. So she might quit taking the blood pressure medicine. She doesn't go to her appointments. And none of this is, I'm saying, like this person's fault specifically. But when you don't get the tools that you need in the beginning, and this is what happens to a lot of women, they're not given the tools that they need in the beginning, even in follow up, about how important blood pressure is. Because down the road, that blood pressure may go away, it may get better. Then you get pregnant again and that blood pressure gets worse. And with that baby, that blood pressure doesn't come back down. But the symptoms for hypertension, do you ever really hear anybody talk about, symptoms for hypertension? Like, oh gosh, you hear about heart attacks, the chest pain, the that's the big one for heart attacks, or like for strokes, some of them it's horrendous headaches. Those are the symptoms that are too late. And what I wanted to touch on is something that I have seen in a lot of women, specifically African American women, that is absolutely devastating. And that is a hypertensive crisis. So that's when the blood pressure goes 180 over 120, but that's a number. We're not walking around with the ability to just read our blood pressure immediately. We have to pay attention to signs and symptoms. And for a lot of women, it's a severe headache. It's the worst headache they've had in their life. And they go to the hospital and they can end up having what's called a hemorrhagic stroke. It's where blood vessels in their brain have burst. And I have seen young women with children who they're absolutely devastated. It's the numbers and the statistics, they're all there, but how do you get to the person, to encourage these women? Because the outcomes that we see are devastating. We have a young woman who is now, their whole family is completely changed. The entire family dynamic is changed once they have that massive stroke. They may not be able to use one side of their body anymore. They may have been working, taking care of their children. Their mother may be working as well. But now we have a complete flip in dynamic. Mom's got to stop working because now she has to take care of her daughter and her daughter's children. Grandma may still be in the picture. Now, grandma's got to help, but grandma's elderly as well. So there's a whole change in a family dynamic. And sometimes that family dynamic is not even there for the mother. Now she has to be put in a nursing home. So now her children have to go visit her. And I think that's what's more impactful to me is we I feel like as a society, we these women get to that point and we're all just scratching our heads like, well, why didn't she do this? Why didn't she do that? It's like, well, what would you have done as a practitioner to help her not get to this point? Now, I know we can't force medicine down people's throats, but sometimes I feel like if we gave them the tools like that they need, that they could help. And the amazing thing to me is as I was researching all of this for this, these statistics, it is alarming the rates compared to Black women to white women, and how there are less Black women in the population in general, but everything is higher. Everything. The outcomes were devastatingly higher, and the percentages were not nominal. It wasn't like a 5 or 10%. No, it was one of the studies I found. This was back in the 90s, where they investigated the pregnancy-related mortality to cardiomyopathy, and they had 171 deaths that were directly related to peripartum cardiomyopathy, and the Black women had a six-fold increase in death compared to white women. And another study they did in Southern California and Louisiana State, where they did 52 Black women who had peripartum cardiomyopathy, showed that they had 11.5% versus a 4.8% mortality rate. Those are significant, and these studies were done a while ago. So what does that mean now? Unfortunately, these things are not going down; they're going up. And excuse me, I'm sorry. I'm still getting over a cold. So that's what I see. And I'd like to tell some stories if y'all don't mind. Now, if you have any questions or if you want me to elaborate on anything, please just let me know. But I got a couple of stories for y'all if you would like to hear them. The first one is a patient I met while I was on case management. I needed to put an updated note, so I pulled up her chart and I noticed that she was on the OB service line. I was like, well, we never have these over here in Maine. They're always over there in the WIC. So she was in her early 20s. She was African American. She was poor. She had very limited access to prenatal care because of the area that she lived in. She lived in a very rural area in Alabama. So I was reading her HMP. She was about 22 weeks pregnant with her first baby, and she started having really bad headaches and blurry vision. So she went to the emergency department, a local ED. They checked her blood pressure. It was elevated, but they only gave her Tylenol and told her just to follow up with her OB within a week because they felt that the elevated blood pressure had to do with her headache, not that the headache was but the blood pressure was causing the headache. So she went home, and per her chart, it said that she failed to follow up, so she didn't follow up with her OB. And unfortunately, one morning, this was a few days later, her mother called her because she didn't show up for work. She didn't answer her phone. She went to the house. She found her down. She was unresponsive. They called an ambulance. They took her to the local ED, who then immediately life-flighted her to a bigger hospital. And CT scan showed a massive hemorrhagic stroke. She was having a hypertensive crisis, but because the doctors at the local ED failed to correlate the two, she went home instead of receiving care. And it resulted in an emergency, what's called a craniectomy. They had to remove part of her skull to allow her brain to swell because she had so much pressure in her head. Unfortunately, they also had to do an emergency C-section, and the baby did not survive. So
So,
she was, go
go
ahead.
ahead. She was.
So she was left. She went through everything. She had it all. She had to be on the vent. She was unresponsive, but she survived. But she survived devastated. Her entire family completely uprooted. completely changed. Now she was living by herself. She was working. She had the baby Medicaid. She was doing what she needed to do for her life. And now she left that hospital. I'll say it's like 100 and something days later. She went home requiring tube feeds, completely bedbound, basically unresponsive. She responded a little bit, but nothing that you would want. And just, it's a wild to think, she was doing everything she needed to do, but now her life has changed. Her mother's life was changed. Her grandmother's life was changed. Her grandmother ended up becoming her full-time caregiver. And her mother continued working to help care for, to provide for the family. And now it was 3 generations of women having to come together to care for the youngest, where all of them were expecting those sleepless nights to be because they got to take care of a baby. But now these sleepless nights are filled with the tube feed pump going off because it's kinked. Or, she couldn't speak anymore, but she could moan, she could yell out in pain. So instead of the cries, now they've got tube feed pumps. They've got that instead. And so, like, that's the human side of the statistics that we look at. Or as you've seen in, the Hulu show Aftershock, it was a mother gone completely. And in another story,
Before
this
you go to
one,
that story, I'm gonna go back to what you said when she went to the ED first,
mm,
and they told her to follow up with her whoever her OBGYN. But I also heard you say that this lady was from rural Alabama.
mhm,
Um, and it just kind of brought back to me a lot of times as a social worker in the hospital, when we look at charts as medical staff, I think sometimes we are, as the staff, are really quick to judge. Like you say, she didn't follow up with her OB, but you got to think about in these rural counties, like you have like maternal deserts. So you have counties who don't even have care in them. So if you're in a rural area, you're dealing with poverty. So it's a whole lot of layers to that. She may have to have paid someone to take her to her appointment. They may have had car trouble. It's just a lot with that. It's a lot with that other than she didn't show up. But from the hospital side, when we see charts like that, these patients are quickly labeled as non-compliant.
yes, they really are. And it's amazing when you sit with them and you dig a little bit farther, you find out there is so much more to the story. And sometimes it is impossible. And this next story that I want to talk about is going to actually expand on that because as I dug through her chart, I did judge her initially, but then as I read more and I found a doctor who decided not to judge, but to dig and asked her tons of questions, the reality of her situation made me really step back and think, it was wrong of me to have judged her as I did. So this next one is I was covering heart transplant one day and there was a patient discharging and she needed a walker. I didn't think much of her. I was like, she was young. She was a young Black lady. She's a very sweet lady. So I went and picked up her walker. She had Medicaid, so I got to use our little DME closet. But when I read her chart, I realized that she was a new mother in the hospital. It's like, what's going on? So I pulled up her chart. I was getting her a whirling walker because she had suffered a cardiac arrest after having her baby. She was there. She survived her cardiac arrest, but she needed a walker because she was severely debilitated after being in the hospital for 60 days. And she had everything. She was on ECMO. She had the vent. She was on the continuous dialysis because everything failed because her cardiac arrest was full blown. But when I went to go talk to her, She was all smiles. She was so happy. She was leaving the hospital. She felt like, I remember she told me, she says, I'm so happy to be alive. She goes, I'm just so happy to be able to go home. She's like, I feel like I've missed so much because I've been in the hospital for 2 months. I haven't gotten to see my baby. She was so ready to get out of that hospital. So I gave her the walker and she left. It was a couple of weeks later, I was back on the service and I noticed that she was back. She only made it home for a couple of days before she returned because she got real short of breath. She got really weak, and her previous admission, she had had an internal defibrillator placed. It fired, so she was back, and she discharged that day that I had her again. She discharged, no needs. Several months later, I was just after her baby's first birthday. She was back. Her heart couldn't take it anymore. She was now back in the hospital on the transplant list. Her heart couldn't do it. She had done everything that they asked of her, but she just couldn't, the heart couldn't take it. The heart would not heal. And the reason why I wanted to talk about her story is when I dug through her chart, I couldn't find anything. The doctor's stories were labeling her as non-compliant, lack of prenatal care, and poor follow-up post-delivery. So I was like, well, what does that mean? But I couldn't find anything about where she was diagnosed with peripartum cardiomyopathy. I couldn't find it. So finally I found one of the transplant doctors. I read her transplant H&P, where they were really trying to dig to see if she was a candidate. And that doctor sat down with her and he really asked her questions. He wanted to know like what happened. And so what he found out is that she said that he asked her, were you diagnosed with any heart issues after you had the baby? And she said no. So he asked her, well, why are you on blood pressure medicine? And she's like, oh, well, she's like, my blood pressure was elevated, during my hospital stay and it wouldn't go down. She's like, I had preeclampsia. So they put me on blood pressure medicine. She's like, she said that, okay. And so he did a little bit more digging and he asked if she had like, were you having what symptoms were you having when you went home? And so she had said that she had been having a hard time sleeping at night, that she would wake up real short of breath and sweaty. And that she felt just really, really tired. And one of the things that stood out to me that she had said is she had complained to her OB about being really tired at a 3-month follow-up. And the OB said, that's normal. You're going to be tired. You just had a new baby. And she said her response to her was, well, how tired do I have to get before this becomes concerning? Because she was exhausted. Now, she had help. She had her mother coming over to help her. Her husband was with her. She had help. This was her second baby. Her other child was older. She's probably about, I think she said 3 or 4. But to her, and she kept telling her OB, I am more tired than the first pregnancy after the first baby. She felt like something was wrong. And unfortunately, what was happening is she had heart failure. She had all the symptoms, not all the symptoms. She didn't have like the really bad swelling of the legs, but she had the nighttime dyspnea, or not able to breathe, and she was so tired. But like I said, they chalked it up to, you're a new mom, you have 2 kids. And now she was sitting on the heart transplant unit waiting for a heart. I never covered that service, so I don't know what happened to her. I don't know if she got her transplant and she got to go home or if she passed away. That what got me with her story was how many women have said, I'm tired, I'm so tired, and I don't think I should feel this way. And they get written off.
That's such a hard, I could, it's hard to think about those type of symptoms and also not think about exactly what her doctor said. Like, you're tired, and that's typical after you've had a baby. A lot of the things, it's kind of like you really, and we've talked about this before, just really knowing yourself and knowing your body. But even in that period of time after you've had a baby, sometimes your body just feels different. Like you can know a lot about it before, but it's never been through that experience before, even if it has, because each pregnancy is different. The other side of it often looks and feels very different. And so it just becomes a thing where if you have that gut feeling that something is going on, you almost just have to become unrelenting in advocating for yourself. Um, and a lot of times we do know, like when something is just off. You know what I mean? It's beyond hormones, beyond just, the typical, like you said, tiredness, but you know when something is off. And so I think just, man, just kind of really just being like, okay, I'm not going to stop talking. I'm not going to stop advocating for myself. I'm not going to stop coming to this doctor's office or seeking a second opinion or doing whatever I need to do because I know that something is not right.
And I got to cover one time, I got to cover OB with a social worker. And it is just, and this is true across the board for any type of hospitalization, whether it be OB, regular. When it's time to discharge, I mean, they're throwing so much information at you, giving you this packet and sending you out the door. And it's like, I have never understood why does nobody the day before discharge, I'm going to sit down with you. These are the medicines you're going to have to go home and let's talk about these side effects. I've never understood why when we send a new diabetic home, we send them home with a blood glucose monitor to make sure they check their blood sugar. Why don't we do the same for blood pressure? What if you wake up, because a lot of young women who do need, blood pressure medicine after having, gestational hypertension, because they are young, their bodies can recover, but they may recover 3 months postpartum, and then they're not going to follow up again for another 6 months. But they were still told to take their medicine, but they don't have a blood pressure cuff at home. Like I've
I
never
thought about
understood.
that, Caitlin. Earlier when you were saying, I literally wrote down blood pressure cuff because I was
Hmm.
thinking about when Erica was saying rural areas and some of the barriers. And we hear all the time, know your numbers, Well, how do you know your blood pressure numbers if you don't have money to get a blood pressure cuff?
Correct. I have
Because that
never
might be
understood
something
that.
that's something that working people can buy or whatever, but then even somebody who's working, who's a low income and just have other priorities, they may not be able to afford that. And so even just something like that to fill in the gap, I may not be able to make it to all of my appointments because there's transportation, but if there's a cuff that's provided where the person could just document along the way what their typical blood pressure is, and then they're able to see patterns and know when it's high. So maybe I need to call the doctor now. Even something like that would be helpful.
And even too, along the lines of when their blood pressure is high, or maybe they feel like I've had some women learn this on their own, is they start getting a headache or they start feeling their vision gets a little bit blurry or they feel off. So they start empowering themselves and they go use that blood pressure. Well, let me see what my blood pressure is. And sure enough, it's high. And they start to correlate, okay, these symptoms may mean that my blood pressure is high. And I feel like that's the piece that we keep missing as healthcare providers is we want to empower people. We want people to do things on their own, but you got to teach them the tools that they need. You can teach the numbers, but what do the numbers mean? And not only teaching them the numbers, but what can happen to you in the long run. Hypertension in women, period, is just different. Hypertension just doesn't, it's such a simple word, but the impact down the line is so much harder. It sends you into renal failure, strokes, heart attacks because of hypertension. Renal failure, the biggest cause of renal failure in African American women is hypertension because the kidneys just can't handle high pressure. They're very vascular, meaning they have a lot of blood supply, they do a lot of work, and they're very soft compared to like the heart. And so they can't handle it. So and Renal failure on top of that is insidious too. By the time you know that you're in renal failure, sometimes you're already in stage 3 and 4 where you're headed towards dialysis because, once again, the kidneys can overcompensate until it's too late. But I really wanted to kind of paint those stories for y'all because I know that they were devastating, but they're real and they happen. And they are what is the worst that can happen to you. But how many people are walking around with these issues that are on the mild form that then down the road turn into the serious? And more, they're starting to correlate heart failure in older women related to their pregnancies when they were younger. Because that
No.
preeclampsia that you had with both all your pregnancies, that gestational hypertension, what did that and the thing is that was not continuously treated. It was brushed off because, once again, women are young when they have babies. That body bounces back, but the body keeps score.
Mm-hmm.
And down the road, go
I'm
ahead.
sorry.
Sorry.
Knowledge is power. So it's just having this information is so good. It gives people stuff to think about. I can't help but just sit here and think like the numbers are higher in African American women for a reason. And we have to go back to kind of begin to dissect what those reasons are. Um, the numbers for hypertension in general in Black people is higher for a reason. It goes back to other things. So I think we have to start looking at what are some medicine is good. I'm glad we have it. Like
Mm-hmm.
it has saved lives. But what are some preventative things? You know what I mean? Like
Yes.
what are some lifestyle changes that need to happen so that we are taking care of ourselves as opposed to having to depend on someone else to take care of us and fix what may be broken. And sometimes it's not an individual's person's fault or any just bad decisions that they're making on purpose when it comes to nutrition or whatever the case may be, stress, all of those things. It could be just simply what they have access to
Mm-hmm.
or the lack thereof. And so, really just kind of making sure too that, and I'm sure somewhere along the line we'll have a podcast to address this. I know next month we're going to be talking about nutritional things, but just what can I do as an individual? I know the numbers, I know the outcomes. What can I do as an individual to help prevent those things from happening in my life, in the life of my children when they're growing up? How am I allowing my kids to eat right now? You know what I mean? Because one day they'll be older, and then if I teach them healthy eating now, what does that look like for them and their generation as they are going through life as an adult? If I teach them healthy, they'll keep that. But if I teach them eat whatever, do whatever, you don't have to exercise, you don't have to prioritize these things, they're going to grow up and that becomes their lifestyle. So I think it's so important too as we talk about the issues, and it is important to talk about the issues, the medical things that happen because that's real. Those stories that you gave, those are real people who are now having to deal with life in a totally different way. You
Mm-hmm.
know, and so it's good to hear that to just kind of bring us back to the reality of what it could be. But I think it's so important also too to think about like now knowing that what do I need to do to change? Because when you get information, now you have a responsibility to do something with it. So,
It is true, and you're right about the rural aspect. One of the studies that I had read was specific to rural African American women, and they did interviews with them throughout their pregnancy about their experiences with prenatal care. And one of the women talked about that she had to walk to her appointments because she didn't have reliable transportation. She didn't have family that could help with that. They were all working during the day when her appointments would be. Another one talked about how she was in her 20s. She was 29 years old. but she looked very young. And when she walked into that clinic, she says she was immediately judged as a teen pregnancy. And she wasn't. She was 29. And as soon as they started, she goes, they talked down to her. Just they gave her pamphlets on like STDs and safe sex awareness because they thought she was a teenager. And then she they looked at her chart and they saw her age completely different. They said they treated her completely different. And it's like, so that's how you're treating a teenager, a young teenager. Because what she said, what she experienced is what the teenagers experience. But one talked about how she had a postpartum follow-up. She had been given blood pressure medicine. And so she couldn't make her appointment because of a scheduling issue. So she rescheduled it. It wasn't 1 to 2 weeks later. It was 2 months later. So she quit taking her blood pressure medicine because she's like, I don't have a blood pressure cuff. You need me to reschedule this appointment, but my first available is 2 months later.
And unfortunately, these are the stories that you highlighted, but this happens every single day.
Mm-hmm.
And first of all, I want to just thank you, Caitlin, for coming on here today. I want to thank you for being such an asset to our organization as we try to tackle some of these things in our community and in some of the rural communities in Alabama. And so I just want to say thank you. Regina, you got anything else?
No, I co-sign everything you just said, Caitlin. Thank you so much for your expertise, your knowledge base in this area. Uh, Thank you for being an advocate and just supporting this cause. We appreciate it. Thank
Thank
you.
y'all for letting me be on. I really enjoyed getting to learn as much as I did, and really seeing how eye-opening these studies are. Because these are studies, these women were real, and how large the gap is between the black women and white women. That many more women, black women, are dying.
Yep. And one thing you said today, the body definitely does keep score. And so I just want to encourage our viewers today to go and follow us on all of our social media platforms and go check out our website at www.thebluerosefoundation.org. And until next time, we'll see you then.